Oh, Kailasanathan. Hi. Okay, so many have joined. Good evening, everyone. We'll wait for Dr. Usha has joined. Yes. I'll make you co-host, Dr. Usha Nandini. Yes. Danyashri, you are made co-host.
Okay, sir.
You can just share and see whether your slides are shared and
Okay, sir.
make a trial. 5 minutes are there. Oh, Dr. UP Singh also has joined. Yes, your slides are seen. Yeah, it's in full screen. You can move it and see.
1 second, sir.
Dr. Usha Nandini also has joined. I have made you Usha Nandini, Dr. As a co-host.
Yes,
And
sir. Yes,
Dr.
sir.
UP Singh also has been made as a co-host. So you can unmute yourself at any time and you can talk.
Yeah, thank you. Thank you very much.
Yes, sir. Thank you, sir.
Can you hear me all loud and clear?
Yes, sir. Yes, sir. Yes, sir. You are loud and clear.
Thank you.
Can I just try to share my screen and see, just check,
Yes.
sir? Is you have
Dania,
time?
Dania, are you able to move the screen or move the images or it's static?
1 second, sir.
Just move the images and you unshare. Let Dr. Usha Nandini have a trial. Yeah, you
1
are.
second, sir. I'll see if my videos are working.
Yes, yes. Just play your videos and see.
Is it moving, sir?
Yes,
Is it playing, sir, the video?
Playing, it's playing.
Okay, sir. I'll stop sharing, sir, then.
Yes, sir. I request the participant to cut off their videos.
I have stopped sharing.
Yes. Dr. Usha Nandini, you can share and
Sure, sir.
trial. You can go full screen and see.
Yeah. Can you see it,
Yeah,
sir?
yeah, it's seen full screen. Yes,
Yeah.
it's moving. Your marker is also seen.
Yeah.
Any videos there?
Yes, sir.
If there are videos, just play it and have a trial. Yes.
Yeah. Done, sir.
Fantastic. So we are all set. Thank you very much. You can unshare. And let me introduce the speaker and the moderators. I'll have my screen shared. You can unshare, Dr. Rushana.
Yes, sir. Yes, sir. Yeah.
Yes. Is my screen seen?
You are seeing, sir. Yeah.
Shall we start?
Yeah.
So as an introduction, I'd like to welcome you all for this weekly meeting of Tamil Nadu chapter of Society of Fetal Medicine on this 13th June, Saturday. We have been having meetings on Sunday, every Sunday for the past 7 weeks, but it was objected by many. And they said Sunday is very busy day. We want to have a holiday, a weekend free for us. So we have shifted it to Saturday, the weekend, so that we can enjoy our Sundays. Today's theme is the fetal cardiac anomalies and the counseling and the postnatal outcomes. We are only going to concentrate on the counseling and postnatal outcomes. We are not going to delve much on the antenatal findings and the ultrasonographic findings. The counseling and the postnatal outcomes is today's theme for the webinar. Meeting agendas. The speakers are common fetal anomalies and counseling is to be done by Dr. Danya Shri, MSOG and DNBOG, who is a fellow in fetal medicine, Doppler scans, Madurai. And postnatal outcomes is going to be done by a dialogue between Dr. Usha Nandini and Dr. Maniram Krishna. Dr. Usha Nandini is in Tiny Heart Center at Tanjore, and both of them are husband and wife working in Tiny Heart Center at Tanjore. Usha Nandini has done her MSc and MBA. I will come to that biodata shortly. And our moderators today are Dr. UP Singh, MDDM Cardiology, who needs no introduction to this August audience because he is a famous national figure and his presence in social media is well known, and his videos in YouTube are very popular, and he teaches so many enthusiasts, so many newcomers into the ultrasound, and we learn a lot of practical points from his videos. Thank you, sir. Thank you, sir, for accepting our invitation and coming into our webinar. Thank you. And he is
Thank you very much.
working as he is a Prime Diagnostic Center and Heart Institute at Chandigarh. And today's another moderator is Karthik Surya, who is an young dynamic pediatrician come pediatric cardiologist who is in Chennai. And the biodata of Karthik Surya is that he completed his pediatrics from Kanji Kamakodi Child Trust Hospital, senior residence of pediatrics at Chettinad Health and Research Institute, and fellowship in pediatric cardiology from Frontier Lifeline Hospital. It's a well-known hospital in Chennai. And junior consultant at Kaveri Hospital from 2014 to 2017. And presently he is a senior consultant at Rainbow Children's Hospital, Kanji Kamakodi Child's Trust Hospital, Frontline Lifeline Hospitals, Surya Hospital, and Kanji Memorial Hospital, and Namar Heart Hospital. So many places he is a consultant. And first I invite Dr. Danya Shri, who has done MSOG and DNBOG from BMC Bangalore, and now she is doing her fellowship in fetal medicine at Doppler scans Madurai, and she did her DNB in OG only after joining our fellowship. She is a very brilliant student, and I wish her all the best in today's presentation. Dr. Usha Nandini, she did her MBBS from Government Thoothukudi Medical College and MBA from hospital administration from PSG Medical College Hospital, Coimbatore. And she has done one of the rare degree, that is MSc in diagnostic ultrasonography, that is from Mediscans in Chennai under Anomaly University. I think she must be the first batch who has obtained that degree, along with probably Dr. Satya Sendil of Coimbatore. And fellowship in fetal medicine she has done at Westmed Hospital, Westmed Sydney at Australia. She has also done fellowship in fetal cardiology, Westmed Children's Hospital at Sydney. She has also done genetics at the same hospital at Sydney. So she's both ultrasonologist, she's a fetal cardiologist, and she is also a genetist. So they're same resume. And Dr. Mani Ramakrishna is a DNB Pediatrics and FNB Pediatric Cardiology, again like Karthik Surya. He's a fellowship in Pediatric Cardiology, Children's Hospital at Westmed, New South Wales, Australia, and consultant pediatric and fetal cardiologist, Tiny Hearts Children's Hospital at Tanjavur and Kaveri Heart City. Dr. B.R. Santanakrishnan, gold medalist for highest national aggregate awarded by NBE. Inaugural Dr. Anisa Saxena Award for Innovation in Pediatric Cardiac Sciences awarded by the Pediatric Cardiac Society of India. He has got more than 50 publications in index journals and international journals. He has got chapter contributions in more than 10 textbooks in pediatrics and pediatric cardiology. Wow. The areas of special interest is inherited arrhythmia syndromes and pediatric cardiomyopathies. So we have feast today from all these stalwarts, and let us start the beginning with the common congenital anomalies and their counseling by Dr. Danya Shri, who is a fellow in Doppler scans. Best of luck, Dr. Danya. I'll unstop my screen.
Thank you, sir.
We can start sharing. Is it stopped?
Is my screen visible, sir?
Yes, your screen is visible.
First of all, I would like to thank Manohar sir for giving me this opportunity. Today, I will be presenting a few cases of common fetal cardiac anomalies and briefly discussing the key counseling aspects for each. This will be followed by talks from our esteemed speakers who will provide a more comprehensive and in-depth discussion of these conditions. So why congenital heart disease matters? It affects 8 to 10 per 1,000 live births and is the commonest congenital malformation. Prenatal diagnosis improves the neonatal outcomes by enabling delivery planning and early intervention. Detailed fetal echo helps identify associated extracardiac and genetic abnormalities. Systematic cardiac screening involves assessing the situs first, then cardiac axis and four-chamber view, followed by evaluating left ventricular and right ventricular outflow tract views. Then assessing the three-vessel view and three-vessel trachea view, followed by examining the ductal and aortic arches. We have to use color Doppler to better delineate the condition, along with the spectral Doppler performed whenever required for further hemodynamic evaluation. An overview of cardiac anomalies which we are going to be seeing today are septal defects, conotruncal anomalies, single ventricle lesions, left-sided obstructive lesions, right-sided lesions, and venous anomalies. Coming to our first anomaly, ventricular septal defect. They are the most frequent congenital heart disease in newborns. They are of different types based on location. Perimembranous VSD, which is the most common type seen in membranous septum just beneath the aortic valve. They are best visualized in the left ventricular outflow tract view. Muscular VSDs are located entirely in the muscular septum. They can be apical, mid-muscular, or anterior and posterior muscular VSDs. Inlet VSD is located posteriorly beneath the AV valve, and it is best visualized in four-chamber view. Outlet VSDs are seen in right ventricular outflow tract view, and based on size, they can be classified relative to the size of aortic annulus as small, moderate, and large. This is a case of an apical muscular VSD located near the cardiac apex, and these are usually an isolated finding. The defect is best visualized on the lateral four-chamber view, where the ultrasound beam is more perpendicular to the apical septum. The apical muscular VSTs may be missed on the standard apical four-chamber view due to acoustic dropout and unfavorable insonation angles. Color Doppler demonstrating flow across the defect is the clinching diagnostic feature, and it helps differentiate a true VST from septal dropout artifact. Bidirectional flow is seen in the antenatal period as compared to unidirectional flow seen in postnatal period, which is due to left to right shunt. In VSTs, prognosis depends on size, location, and associated anomalies. Isolated small muscular VSTs often close spontaneously during fetal life or infancy in up to 50 to 80% of the cases. Isolated VST generally has excellent survival of more than 95% after closure. This video shows the catheter-based closure of the VST. Increased risk of chromosomal abnormalities should be suspected when VST is large, perimembranous, multiple, or associated with extracardiac anomalies. And genetic evaluation should be offered if additional markers or anomalies are present. And recurrence risk in a future pregnancy is approximately 3 to 5%. Moving on to the next anomaly, complete atrioventricular septal defect. It involves membranous VST with ostium primum AST and common AV valve. They can be balanced or symmetrical type, of which 40 to 50% are associated with trisomy 21 cases, and unbalanced or asymmetrical type, which are usually associated with isomerism, AV block, and other malformations. This is a case of complete balanced AV canal defect. In four-chamber view, loss of normal crux of the heart is seen. A characteristic defect is seen at the center of the heart, involving both atrial and ventricular septa. On color Doppler, inflow through the common valve enters both the ventricles simultaneously, resulting in merging of the right and left ventricular flow at the level of AV junction, producing the characteristic H sign. The right and left ventricles appear similar in size. The common AV valve opens symmetrically into both ventricles. This case also had ARSA. AVSTs usually have strong association with Down syndrome. Hence, genetic testing should be offered. Also, they are associated with heterotaxy syndromes and other extracardiac anomalies. Prognosis depends on the presence of chromosomal abnormalities, associated cardiac or extracardiac anomalies, degree of AV valve regurgitation, and ventricular balance. Progressive cardiomegaly and heart failure may occur when significant AV valve regurgitation is present. Delivery should be planned at a tertiary center. Definitive treatment is surgical repair at 3 to 6 months of age with long-term survival exceeding 85 to 90%. Some children may require re-intervention for residual AV valve regurgitation or left ventricular outflow tract obstruction, especially in unbalanced AVST cases. Recurrence risk in future pregnancy is approximately 3 to 4%. The next anomaly is tetralogy of Fallot. It is the most frequent conotruncal congenital heart disease, accounting to 8 to 12%. The components involved are ventricular septal defect, overriding aorta, and pulmonary pathology. Incidence is 1 in 1000 to 2000 newborns. So the fourth component is right ventricular hypertrophy, which is not seen in fetal period as it develops postnatally over a period of time. In this case, in the top left image, we can see the fetal cardiac axis shows left axis deviation. Left ventricular outflow tract view shows the subaortic VST, and aorta is seen overriding and receiving outflow from both ventricles in a Y-shaped pattern. In a Y-shaped pattern. This is clearly seen on color flow mapping. In three-vessel view, a small pulmonary artery is seen with forward flow across it, and the typical V confluence is not seen. Z-scores of aorta and pulmonary artery have to be calculated. Z-scores of aorta is in plus and Z-scores of pulmonary artery is in minus. Prognosis depends on the pulmonary artery pathology. In cases with pulmonary stenosis, survival is more than 90% after repair. And cases with pulmonary atresia, survival is up to 70%. And in cases with absent pulmonary valve, they have a guarded prognosis. Prognosis also depends on pulmonary artery size, presence of MAPCOS, and associated genetic and extracardiac anomalies. Associated chromosomal abnormalities are seen in up to 20 to 30% of TOF cases, particularly 22q11.2 deletion. Serial fetal echo is recommended to monitor growth of the pulmonary arteries and progression of right ventricular outflow tract obstruction. Definitive treatment is complete surgical repair, often at 3 to 6 months of age. Neonates with severe obstruction or pulmonary atresia may require staged management. Prostaglandin infusion after birth and initial shunt or stenting procedure, followed by a complete repair. This shows the modified BT shunt where stent is placed between branch of aorta and right pulmonary artery to improve blood flow to lungs. Long-term survival after repair exceeds 90 to 95%. Recurrence risk in future pregnancy is approximately 2 to 3%. Next is transposition of great arteries. It involves atrioventricular concordance and ventricular arterial discordance and comprises 7% of the congenital heart diseases. In this case, there was normal cardiac access and situs. Ventricle sizes are symmetric. Veno-atrial and atrioventricular connections are concordant. There was a perimembranous muscular VST seen in the outflow tract view. The parallel rather than crossing great arteries in the outflow tract view is the key diagnostic sign. There is ventricular great arterial discordance. Morphological right ventricle is seen giving rise to aorta, and morphological left ventricle was giving rise to pulmonary artery. So this was a case of TGA with the VST. In 3-vessel view, the V sign is absent. Only 2 vessels are seen, aorta and SVC, producing the capital I sign. This is because the pulmonary artery bifurcates at a lower level. Prognosis depends on presence and size of intercirculatory shunts, foramen ovale, ductus arteriosus, VST, associated cardiac anomalies, and restriction of the foramen ovale. Serial fetal echo is recommended to assess foramen ovale patency, ductal flow, and ventricular function. Neonates commonly require PGE1 infusion to maintain ductal patency. Balloon atrial septostomy is done if interatrial mixing is inadequate. This video shows the balloon atrial septostomy. Definitive treatment is the arterial switch operation at first 1 to 2 weeks of life. Genetic abnormalities are less common than in AVST or TOF. Recurrence risk in future pregnancy is approximately 1 to 2%. Double outlet right ventricle. It has a dual right ventricular outflow tract. When the greater part of circumference of both arterial valves are supported by right ventricle, and there is absent fibrous continuity between mitral and aortic valves. Functional classification of DORV includes TOF type DORV and TGA type DORV. This case, the 4-chamber view is normal with normal ventricular sizes and AV valve offsetting. Veno-atrial and atrioventricular connections are normal. In the top left image, we can see both the great vessels are in side-by-side orientation and malpost. Aorta is seen arising anteriorly from RV. More than 1.5 portion of the great vessels are committed to right ventricle. And pulmonary artery is seen arising posteriorly from right ventricle and is bifurcating at a lower level and is smaller than the aorta. In the outflow tract view, subaortic VST is visualized. The left ventricular outflow is reaching aorta through the VST. The relationship of the great arteries and VST location determine the specific DORV subtype and also the surgical approach. Prognosis depends on VST location, presence of pulmonary stenosis, associated cardiac and extracardiac anomalies, ventricular adequacy, and complexity of repair. DORV they are frequently associated with chromosomal and genetic abnormalities, hence genetic testing should be offered. Most infants require surgical correction in infancy. Surgical approach may include single-stage biventricular repair for favorable anatomy or staged surgical palliation when biventricular repair is not feasible. Long-term outcome in DORV is generally good after successful repair, but is more variable than for isolated TOF or TGA. Moving on to next case, this was a 20-week fetus with normal situs, and a 4-chamber view shows mild left axis deviation. There is subaortic VST and a single large arterial vessel is seen overriding the ventricular septum in the outflow tract view. The single arterial trunk receives blood from both the ventricles. Venoatrial and ventricular-atrial connections were normal. In the top left image, in 3-vessel view, the normal 3-vessel arrangement is lost. Only a single large vessel and SVC are visualized. Pulmonary artery is seen arising posteriorly from the large vessel and bifurcates after the common origin. So this was a case of truncus arteriosus. They are frequently associated with 22q11.2 deletion. Prognosis depends on associated chromosomal or extracardiac abnormalities, truncal valve function, pulmonary artery anatomy, and ventricular function. Neonates typically develop pulmonary overcirculation and congestive heart failure within the first week of life if untreated. Early complete surgical repair is required, usually in the early neonatal period. Long-term survival after repair exceeds 80 to 90%, but multiple reinterventions are common during childhood and adulthood, particularly for conduit replacement and truncal valve disease. Moving on to next case. So this is a case at 22 weeks. The fetus was in cephalic position. In this axial section of upper abdomen, the stomach should be seen on the left side because fetus is in cephalic position. But here the stomach bubble is seen on the right side, indicating site is ambiguous. There is a juxtaposition of aorta and IVC on the same side, and a symmetric midline bilobed liver is seen. This case, in the top left image, shows the similar right atrial morphology of pyramidal shape on both sides. And in the 3-vessel trachea view, we can see bilateral SVC, indicated by the arrows. 4-chamber view shows absent crux with small left-sided chambers and dominant right-sided chambers with a common AV valve, indicating an unbalanced AVST. Both the great vessels are seen arising from anterior right ventricle. Aorta is seen arising anteriorly and pulmonary artery is seen arising posteriorly and bifurcating. They are malposed in side-to-side position, suggestive of DORV. In this 4-chamber view, the pulmonary veins are not seen draining into left atrium and forming a confluent vein posterior to the left atrium, indicated by the arrow. The space between the left atrium and aorta is also increased. In the same case, in the mid-sagittal plane, a vertical vein is seen from the thorax into the abdomen, draining into hepatic vein. The vertical vein is marked with arrows in the 2D image. And the spectral Doppler trace over the vertical vein shows a continuous venous flow pattern. So this was a case of right atrial isomerism with the unbalanced AVST and DORV with infracardiac TAPVC. It represents a severe form of heterotaxy syndrome with complex congenital heart disease. Associated abnormalities may include abnormal systemic and pulmonary venous connections, abnormal cardiac position and conduction defects, splenic abnormalities, often asplenia, intestinal malrotation, and other extracardiac anomalies. Infracardiac TAPVC carries a high risk of pulmonary venous obstruction and neonatal instability. The long-term complications in this case includes arrhythmias, heart failure, Fontan failure, and complications related to asplenia. Parents should be counseled regarding the possibility of multiple surgeries and lifelong cardiology follow-up. Genetic evaluation should be offered, although a specific chromosomal abnormality is less consistently identified than in AVST or conotruncal defects. Despite advances in surgery, morbidity and mortality remain high for these conditions. Now coming to left-sided obstructive lesions. Aortic stenosis. Narrowing is seen at the level of aortic valve, which causes an obstruction of left ventricular outflow. It can be...
Dhaneshri, you got
Yes,
only
sir.
5 minutes more. Just you can move fast.
Okay, sir. Okay, sir. It can be of supravalvular, valvular, or subvalvular types, valvular being most common in the prenatal period. It can be mild to moderate, critical aortic stenosis, or aortic atresia. In this case, in the four-chamber view, it shows a globular left ventricle, which was akinetic with echogenic walls indicating endocardial fibroelastosis. There is a dilatation of left atrium, and the arching of foramen ovale flap towards right atrium is also seen. In color Doppler of four-chamber view, it shows adequate trans-tricuspid flow with minimal transmitral flow. Mitral regurgitation is also seen during systole. And it also shows reversal of foramen ovale flow. In left ventricular outflow tract view, aortic valve is thick and stenotic with limited excursion. Ascending aorta and transverse aortic arch are smaller in size and show reversal of flow from the ductus, representing a case of critical aortic stenosis. And the spectral Doppler traces in the pulmonary valve, spectral Doppler trace in this pulmonary vein shows reversal of flow during ventricular systole. And the spectral Doppler over mitral valve shows mitral regurgitation. Prognosis depends on the severity of valvular obstruction, left ventricular size and function, presence of endocardial fibroelastosis, and progression to hypoplastic left heart syndrome. Mild to moderate cases may remain stable throughout pregnancy. Severe fetal aortic stenosis can lead to HLHS and hydrops. Selected fetuses with critical aortic stenosis and evolving HLHS may be candidates for fetal aortic valvuloplasty in specialized centers. This video shows the fetal aortic valvuloplasty, usually done between 20 to 30 weeks, wherein a guide wire and balloon catheter are advanced across the stenotic aortic valve. The balloon is inflated to dilate the valve and improve antegrade flow through the aorta. Outcomes are highly variable, with mild to moderate lesions generally having a favorable prognosis, whereas severe disease progressing to HLHS carries a significantly higher morbidity and mortality. Next anomaly is the coarctation of aorta. It is characterized by narrowing of the aortic isthmus or arch leading to obstruction of systemic blood flow. This was a 24-week fetus with normal situs. Four-chamber view shows a right-sided chambers more prominent than the left chambers. And three-vessel view shows a persistent left SVC seen in this top left image, which was draining into dilated coronary sinus measuring around 4 to 5 mm. There was no right SVC. Mild narrowing is seen at the level of transverse aortic arch as compared to descending aorta and ascending aorta, indicating a juxtaductal coarctation of aorta. The same was demonstrated in 4D stick rendering. Measurements of mitral valve annulus, tricuspid valve annulus, left ventricular and right ventricular diameter, ascending aorta and aortic isthmus were obtained, and their Z-scores were assessed to evaluate for hypoplasia and disproportion. Prognosis in these cases depends on the severity of arch obstruction, presence of associated cardiac anomalies, left ventricular size and function, and associated genetic abnormalities. This coarctation of aorta have a strong association with Turner syndrome. And they are commonly associated with bicuspid aortic valve, VSD, and other left-sided obstructive lesions. Definitive treatment consists of surgical repair in early infancy. This video shows the surgical repair usually done through a left posterolateral thoracotomy. Long-term survival after repair is excellent, more than 90%, although lifelong follow-up is required for recurrent coarctation, hypertension, and associated aortopathy. Next is the hypoplastic left heart syndrome, wherein there is hypodevelopment of the left heart, microaortic atresia, aortic stenosis or atresia, coarctation of aorta. They all can lead to hypoplastic left heart syndrome. In this case, in 4-chamber view, no connection is seen between left atrium and left ventricle. There is no flow across mitral valve, and there is hypodevelopment of left ventricle. Left ventricle is reduced in size, does not show contractions, and is globulous. The walls are thick and echogenic, suggestive of subendocardial fibroelastosis. In 3-vessel trachea view, reversal of flow is seen at the level of aortic isthmus. Prognosis depends on the presence of a restrictive or intact atrial septum, ventricular function, associated chromosome or genetic abnormalities, and serial fetal echo is recommended to assess the ventricular function and progression of disease. Neonates require a PGE1 infusion to maintain ductal patency and systemic blood flow. Biventricular repair is not feasible. Standard management involves staged single ventricle palliation. Stage 1 involving the Norwood procedure done during first week of life. Stage 2 is bidirectional Glenn shunt done at 4 to 6 months of age. And stage 3 is Fontan procedure usually done at 2 to 4 years of age. Next is this is a right-sided aortic arch with left-sided ductus and aberrant left subclavian artery. In this condition, in 3-vessel trachea view, the trachea is seen as an echogenic structure between the transverse aortic arch on the right and the ductus arteriosus on the left. These vessels surround the trachea in a U configuration. In almost all cases, there is an aberrant course of the left subclavian artery arising from the region of the junction of ductus arteriosus with the descending aorta. It is considered a loose vascular ring as compared to a tight vascular ring, which is seen with the double aortic arch, in which case it forms a complete circle around the trachea. This right below video, it is of double aortic arch, which forms a complete circle around the trachea. They have an increased association with 22q11.2 deletion, especially when associated with thymic hypoplasia. Isolated cases generally have excellent prognosis post-surgery. Postnatal assessment is recommended to evaluate for airway or esophageal compression, especially in cases with double aortic arch. The infants develop stridor and feeding difficulties and require surgical division of the vascular ring. Long-term outcome after repair is excellent. For our last case, we will discuss a case of a single ventricle lesion. Here, both atria are opening by separate AV valve into a single large dominant ventricle. The ventricle has smooth endocardium with no moderator band, indicating a left ventricular morphology. Color flow mapping reveals merging of both ventricular inflows in the single ventricular cavity. A small rudimentary bulboventricular foramen is faintly seen. Veno-atrial connections are normal. The single ventricle gives rise to both the great vessels, with pulmonary artery arising posteriorly and aorta arising anteriorly, indicating malposed great vessels. Both the great vessels are of normal size. The pulmonary artery is recognized by its bifurcation, while aorta is recognized by its uninterrupted continuity into aortic arch. So this is a case of double inlet left ventricle. Prognosis in these cases depends on the presence and severity of outflow tract obstruction, ventricular function, AV valve regurgitation, and associated cardiac and extracardiac anomalies. Most patients require a staged single ventricle palliation. Stage 1 is the neonatal palliation, Stage 2 is bidirectional Glenn shunt, which is performed at approximately 4 to 6 months of age. This video shows the bidirectional Glenn shunt, wherein SVC is connected to pulmonary arteries. And stage 3 is the Fontan procedure, which is performed at 2 to 4 years of age, wherein the IVC is connected to the pulmonary arteries. Genetic evaluation should be considered, particularly when extracardiac anomalies are present. Thank you. This was a brief overview. Now we will hear from our esteemed speakers.
So that was an excellent presentation, Dr. Danyashri. Thank you very much for your keen preparation and presentation with a lot of videos and a lot of animations as well. Thank you very much, sir.
Thank you, sir.
Comments from you, sir, Dr. UP Singh, sir. Dr. UP Singh, sir, you are muted, sir. You can unmute. Yes.
Yeah. I'm okay. I think we've already spent good time, and it was a very brief overview of all congenital abnormalities in a one 30-minute talk. I think this was fabulous. But I don't want to make any comments right now. Maybe we'll answer the questions later.
Yes.
There had been one query in my WhatsApp group that the number has exceeded the expectation, and now I
Yes,
think
sir.
your
But the limit is only 100, sir. Limit is only
yeah,
100.
and people, are you live streaming it or you're not?
No, sir, we are not live streaming.
You're not.
Yeah.
Anyway, I think you can make a recording and then
Yeah, we are
they can
making a
show.
recording, sir.
Yeah.
We'll make them available for those who are not attending today.
Yeah.
Thank you, sir. It's a good response because you are there.
No, I think the speakers are fabulous.
No, sir. You are the crowd puller.
Oh, thank you.
Thank you for being with us, sir. Any comments, Karthik Surya? Karthik Surya, are you there? You are made a co-host and you can unmute yourself and you can speak. Karthik?
Yes, sir. I'm here, sir.
Any comments from you?
Okay, it's an excellent presentation, sir. As Singh sir said, I think we can just proceed. Let Dr. Usha and Dr. Mani finish, and then we will
We'll
take
answer
any
the
questions.
questions.
Actually, it was more than brief. It was more extensive, is
Yes,
what
yes.
I felt, actually. It's pretty extensive. Anyway, good coverage, sir. Actually, the entire spectrum was covered nicely. I think we should just proceed, and then we can take
Yes.
questions at the
Now
appropriate
may I
time.
invite
Definitely, sir.
Dr. Usha Nandini to proceed with her talk on postnatal outcomes of the common congenital with Mani Ramakrishna.
Yeah. Hi, sir. Nice to see you all. Thanks for the opportunity to Manohar, sir, and all the audience here, to all the seniors and juniors, and special thanks to Karthik Surya, sir, and UP Singh, sir. Karthik, sir, nalla irukingla? Okay, so
Fine, thank you.
So I and Manirama are here to present on some of our work which we do on such a small place like Tanjavur. And thanks for the lovely introduction, sir, about us. And Maniram?
Yeah, so thank you once again, sir, for this opportunity. So we're just going to have a discussion about cases. So, many times fetal medicine, the problem is you won't know to correctly predict the postnatal outcomes, which is where, as pediatric cardiologists, we'll be able to help you out. So what we are trying to recreate today is essentially how we discuss every single cardiac patient which we see in clinic.
Yeah. Shall we start, sir? Manohar, sir?
Yes, sir. Yes, please.
So we all know that, and first of all, it was a wonderful, very extensive presentation by one of your fellows, sir. I think she has covered everything in cardiology. And as we know, I always start with this slide because we know that the incidence of CHD is much higher than chromosomal abnormalities. But still, we do not have a proper protocol to identify CHDs. Whereas for chromosomal abnormalities, everybody has started doing Down syndrome screening and all those. And when I talk about CHD, I always feel, especially after working in cardiology for some time and after marrying a pediatric cardiologist and after being in a pediatric cardiology unit for quite a while, I feel that most of the CHDs are treatable and they do have good outcomes. So hence, I think like all the pregnant women should be subjected for a proper fetal echocardiogram, and they need to be counseled properly, and their choice should be like, their decision should be the proper informed choice. So it's not just about imaging or scan, and it's all about the outcome which we are keen. And I think we will be able to achieve a proper outcome, especially in cardiology, when we involve the pediatric cardiologists. So seeing is believing. So I started believing that CHD kids can do well only after I started working in pediatric cardiology. My first mentor was Dr. MS Ranjit in SRMC. And like that's when I understood that yes, CHD kids can do well, and they do have a normal, normal lifespan. Most of them are like correctable surgeries. Only a small chunk is like palliative ones. And the key is right diagnosis at the right time, and accurate prediction of the outcome would definitely help the parents to take a proper decision. And this always, like in UG and PG, we don't have much understanding about cardiology, and we struggle to listen to a murmur, and we expect a blue baby with a low SATs, and we don't know what the diagnosis is, and even if we know, we don't know what the hemodynamics is. And the moment we see a CHD, the first thing which comes in is like pack up and just refer to a higher center.
So, but actually, I think it's not just about, referring immediately, especially when you work in a smaller center, it becomes a bit difficult to immediately send the patient to a big city. Say you diagnose it in an anomaly scan. It is not realistic for the family to go and stay in a bigger city for 5 months, have the delivery and get the treatment done. So I think the most important thing is to try to predict how the baby is going to be in the newborn period based on the antenatal scans, and to get the diagnosis completely right. So when we do that, you will see that a vast majority of these disorders can actually be delivered in the primary level itself, and then the baby can be referred for the evaluation as and when needed. So, for example, even tetralogy of Fallot, if the antegrade flows are very good, then the baby can be safely delivered even in a smaller center, and can be sort of semi-electively referred to a pediatric cardiologist for evaluation. So this antenatal period actually gives us a wonderful opportunity to triage the patient so that we can decide which patient needs delivery and advanced care in the early newborn period, and who can be sort of seen more electively.
The role of cardiac genetics, and we still think that are we there yet? But I think by end of this presentation, I think the audience will be able to understand whether are we there yet, especially with regards to inherited arrhythmias or cardiac genetics, and what is the role of this in prenatal diagnosis. So we'll run through few case scenarios, real-time case scenarios, which we handled personally in our unit. And sir, if we are running short of time, please feel free to stop us anytime, sir. I think because we have some 10 case scenarios. So first case is like G2L1 mother, refer for a scan at 25 weeks. The anomaly scan was done elsewhere, and she had an amniocentesis for high risk for Down syndrome in first trimester screening elsewhere, and the history was uneventful. And when we saw the images, it was when I did a fetal echocardiogram, then this is what I saw, and we could see a vertical vein beautifully running down into the abdomen, and it was intracardiac diaphragm TAPVC.
So TAPVC, again, it's a surgical emergency, especially intracardiac TAPVC. We know this when we were interns, we were always told the sun should never rise and set on a obstructed bowel. I think the same applies even for intracardiac TAPVC. Sometimes, you deliver, you confirm the diagnosis and straight away shift the baby to the cardiac OT for surgery. So this is one condition where you don't have any, temporizing treatment. So you need to deliver them in a cardiac surgical facility. So we counsel the family appropriately. and the baby was delivered at 39 weeks by LSCS. Again, you can potentially deliver, allow this for normal delivery, but this involves having the entire team ready to operate on the baby if needed within a few hours. So it might be reasonable to have a planned delivery. The baby again was a very good weight, 3 kilograms, and had to be operated on the same day. So we confirmed the diagnosis in the NICU and then straight away prepared the cardiac OT for surgery. And the post-op recovery was completely uneventful. The child is now 5 years old and is actually going to first standard this year.
Maniram, you can switch on your video also.
Yes, sir.
Your video was not seen.
Yes.
Yes, now you are seen. Thank you.
So what happens if this was missed antenatally? So again, as I said, this is a real emergency. Most of these babies usually become unstable within the first few hours of life. And if there is no cardiac surgical facility available nearby, many of them might actually die within the first few days of life. What if it's a... Yes.
So this was a G2L1 mother. The first trimester screening showed low risk for Down syndrome, and at the 18 weeks, who reported as cystic hygroma, and amniocentesis was done elsewhere, reporting a normal karyotype. And at 33 weeks, she was referred to us for bilateral pleural effusion, which showed where when we did the ultrasound, we found that the right effusion was more than the left. And on echocardiogram, we found that the baby had mild left ventricular hypertrophy as well. On follow-up, the effusion on the right was increasing. So whenever we say increased NT with ventricular hypertrophy and pleural effusion, there's only one thing we should think of for this triad, which is Noonan syndrome. So we counsel the family that the possibility of the genetic abnormality, and since she was 34 weeks, we were not going for any prenatal diagnosis, as we know, and we delivered the baby at. So she ruptured her membranes at 36 weeks, and we delivered the baby by LSCS. The baby weighed 2.1 kilos.
So postnatally, the baby had significant respiratory distress. And as we had suspected, there was a very large pleural effusion on the right and a moderate sized effusion on the left. The echo was structurally normal. There was some ventricular hypertrophy, but the function was normal and there was no outflow obstruction. Next. So we proceeded with ultrasound guided pleural fluid trapping, and we drained nearly 40 ml of serous fluid. Once the fluid was removed, the respiratory distress settled immediately. This baby did not have any reaccumulation of fluid after the initial tapping and was actually discharged home within a week. And as we had told you prenatally, our suspicion was Noonan syndrome. We did genetic testing after birth, and this confirmed our suspicion of Noonan syndrome. So the importance of making this diagnosis even prenatally is that there are a lot of complications related to Noonan syndrome, which can occur in postnatal life, and you can anticipate these complications and treat them accordingly. So this is where genetics plays a very important role.
So this was a primary mother referred as bradycardia at 30 weeks of gestation. And as we can see, the heart rate for the baby, the ventricular rate was only 44 beats per minute. And it was complete heart block with AV dissociation. And the atrial rate was normal, whereas the ventricular rate was only 44, and there was no evidence of hydrox. So we made the diagnosis of heart block, and we wanted to start the mother on therapy for this. Always, it's better to hospitalize these mothers because we are putting the mother under some medication. So we need to monitor the mother and the baby as well. So whenever we start on oral salbutamol therapy, we prefer to admit the mothers. And then parallelly, we do evaluation for the ANA profile as well. And she was SSA, SSB positive. We were following her up closely. And what we do is we start the mother on salbutamol. And then we monitor the baby and we see how the heart rate picks up. And then we discharge her, and when we ask her to come maybe once in 2 days or every day sometimes. And this particular baby was going in for growth restriction. And And there was oligohydramnios with an altered CPR. When the CPR is altered, we decided to deliver this baby. And the baby was weighing 1.4 kilos and was shifted to our NICU.
So before you go to the postnatal treatment, just a couple of things which I'd like to mention. I know once you have established heart block, there's probably no role for immunomodulatory therapy. Now, all of us, or many of us, when we see heart block, we immediately start the mother on steroids or sometimes even IVIG therapy. So once there is established heart block, you cannot reverse it. So there is no point in giving immunomodulatory therapy to the mother. So there are probably a couple of places where immunomodulatory therapy may be of role. The first is, when heart block is developing, when you are starting to see an increase in the AV interval, or if you are just seeing the baby the previous day, the AV interval was normal, and then you are seeing features suggestive of heart block the very next day. So that is one place where immunomodulatory therapy can have a role. And if there are any features to suggest endocardial fibroelastosis, then there might be some role for trying immunomodulatory therapy. The second thing, again, go by the CPR rather than individual Dopplers when you decide to deliver the child, because as we all know, Doppler is dependent on the stroke volume, and because the heart rate is very low, the stroke volume is always very high, and you might have abnormal values. So you need to average out these abnormalities, which is where the CPR might be very useful. So in this particular child, postnatally, we delivered the baby. The birth weight was 2.1 kilograms, and the heart rate was only 44 per minute. So we started the child on some therapy to improve the heart rate. So typically, we start them on an infusion of isoprene to maintain a heart rate of above 50. And then this child had a pacemaker inserted in the newborn period. This is her on her third birthday. Now she is 6 years old. Now, can we prevent this from happening in the next pregnancy as well? I think nowadays we have a very good way of doing it, which is by prophylactically starting oral hydroxychloroquine for the mother. So you need to reach a dose of at least 400 milligrams by first trimester, so before 10 weeks of pregnancy. So this particular mother again conceived, and we started her on hydroxychloroquine prior to conception, and followed this pregnancy closely. This baby did not develop heart block. You can see the younger kid here, and she's completely fine. We are actually right now in the process of reporting our early experience with hydroxychloroquine in mothers with antibody positivity, as well as a previous child with heart block. And we had followed up 23 pregnancies in 19 mothers, and we have not had a single case with fetal heart block. So this is one therapy where you can potentially prevent it in future pregnancies as well. Next.
So all our complete heart blocks so far, which we have diagnosed antinatal, have survived. And there was one interesting mother which I would like to share, because she had recurrent complete heart block. First child had bradycardia, and the child died immediately after birth. But there no proper documentation except a small paper which stated that the heart rate was about 40, 44. And the next time she was on a proper follow-up and scans were done appropriately and diagnosed to have heart block around 24, 25 weeks as per the records. And she was started on steroids, and which led to severe fetal growth restriction, and the baby died in utero. So this is what we have realized, that once the heart block is established, there's absolutely no role for steroids, and sometimes it can cause more harm than benefit. And the third time she was referred late, of course, at 30 weeks only, and the baby had bradycardia, already set in with some fetal growth restriction. And we delivered the baby at 1.3 kilos. And I think this was a challenging patient, because one of the few youngest children to have pacemaker done with such a low birth weight. And now she's 4 years of age. So this is about the vascular rings. I'm showing two case scenarios. One is like a mother who was referred to as a 21 weeks for second opinion for right aortic arch, was advised termination elsewhere for this. On proper evaluation, then we found that it was actually a double aortic arch. Whereas the other mother, she was referred for a fetal echocardiogram as a routine. And at 24 weeks, we found that there was ARSA with left aortic arch with aberrant right subclavian artery. For both of these patients, we did amniocentesis, and we followed up the pregnancy till term. And for double aortic arch, as we all know, better always to deliver these babies in a tertiary cardiac facility, because this babies will require immediate cardiac evaluation, and there's no contraindication for vaginal delivery. So we delivered the baby at 37 weeks. And then the other one, we asked the primary referring obstetrician herself to deliver at her own place, because left arch with aberrant subclavian artery is not going to present as an emergency. And the baby was delivered at 38 weeks and then shifted to our NICU.
So the baby with double aortic arch was delivered vaginally at 39 weeks. So you can see the double aortic arch in the fetal stick images. We were able to confirm it on a postnatal echocardiogram as well. So you can see clearly that both the arches are completely patent. The right arch is the bigger one, but the left is also a reasonably big size vessel. And you can see the trachea being completely encircled by the arches and the head and neck vessels. So this results in a complete vascular ring, and more often than not, these babies will be symptomatic in infancy itself. Next. So the baby with double aortic arch underwent surgery. It was not very symptomatic in the newborn period, but within 2 to 3 months started developing stridor, especially when there was some respiratory symptoms. So the baby was operated at 4 months of age. As we had seen in the CT scan, the left arch was slightly smaller than the right. So the left arch was ligated, and this resulted in an almost instantaneous improvement in symptoms. Whereas the other baby, who had an aberrant right subclavian artery, has not had any symptoms and has not received any treatment for the same. Some of them can develop dysphagia due to esophageal compression, because aberrant right subclavian is an incomplete vascular ring. And if they have symptoms suggestive of dysphagia, they may need to get operated. This is almost never necessary in the first year of life. Next.
So this was mother, G2L1 mother, married for 3 years, referred as 26 weeks. Second opinion for transposition of great arteries. On echocardiogram, we found that it was transposition of great arteries with intact ventricular septum. And it appeared like the PFO was restrictive. And
so what do we do next? So we followed this baby up closely every 4 to 6 weeks. And at 32 weeks, we had a suspicion that the PFO was very restrictive. Now, this is going to be a nightmare for many of us pediatric cardiologists, because these babies with TGA have excellent outcomes with an arterial switch operation. This is probably a single surgery with a very low mortality rate and very, very low complication rate on follow-up. But one concern is some of these babies can become very sick within the first few days of life if there is no adequate atrial level shunt. So they may require a procedure called a balloon atrial septostomy in the first 1 or 2 days of life to sort of stabilize the baby before surgery. And our concern is there a very good way of predicting whether this baby will require a balloon atrial septostomy in the immediate newborn period?
so how do we predict this potential restrictive atrial septum? So we performed maternal hyperoxygenation test to exactly predict whether this baby will be in trouble and whether the baby would require balloon atrial septostomy.
So what we are trying to do with the maternal hyperoxygenation is we are trying to induce the postnatal hemodynamics in fetal life itself. So generally the main difference between fetal and postnatal life is that the pulmonary blood vessels are completely collapsed and there is very little flow happening into the pulmonary arteries. So what we do is we try to relax these pulmonary arteries by administering oxygen to the mother and promote flow within the pulmonary arteries. So it can be used for a variety of cardiac conditions, but in TGA, we are looking at 2 things. We are looking at the foramen ovale and the ductus arteriosus. So as far as the foramen ovale is concerned, we measure the size of the foramen ovale, see if it increases after administration of oxygen. And then we also look at the direction of shunting across the foramen ovale. So in the baseline state, you will expect shunt to happen from the right atrium to the left atrium, whereas with hyperoxygenation, you would expect a bidirectional shunt. If this bidirectional shunt does not occur, then there is a high possibility that this baby will require a balloon-atrial septostomy. The other thing which you also look for is the flow across the ductus arteriosus. So you should anticipate a retrograde flow. If that does not occur and there is only antegrade flow, then again there is a high possibility that this baby would require a septostomy. So in this particular baby, all of the features suggested that there would be a requirement for a septostomy soon after birth. Next. So this was the maternal hyperoxygenation being performed. Next. So this baby was delivered at 36 weeks with a birth weight of 2.3 kilograms. As we had predicted prenatally, the foramen ovale was very restrictive. The saturation was good immediately after birth, but within an hour had dropped to less than 80%. So we did not start prostaglandin. We actually went ahead with a balloon-atrial septostomy. Next. You can see a very small communication between the atria. So in our unit, we perform it under ultrasound guidance. So we don't shift the baby to the cath lab. So we do it in the NICU itself. Next. So you can see that there's a very small shunt. So we do it through the umbilical venous route itself, which saves us a lot of time and effort. So we cannulated the umbilical vein. Next. This is the septostomy catheter, septostomy balloon catheter, which we use to perform the procedure. Next. So we cannulated the umbilical vein with the septostomy catheter. Next. And then we pass the balloon from the right atrium to the left atrium. And while once we are inside the left atrium, we dilate the balloon with saline, fill it up. Next. So you can see the balloon filled up inside the left atrium. So we pull it towards the septum and then give a jerk to pull the balloon, the dilated balloon across the septum, tearing the septum. Next. So you can see we are inflating the balloon under ultrasound guidance. Once we are happy that we are in the right position, we just pull the balloon quickly across the septum. This results in a tear in the septum. And almost immediately, you can see an improved shunting across the atrial septum, as well as a significant increase in the saturation. Next. So the beauty of balloon septostomy is that, you don't need anything else. You can shift the baby to the mother's side. You don't even have to keep the baby in the NICU. And you can plan the surgery sort of semi-electively within the first 1 to 2 weeks of age. So these are some of the other conditions where maternal hyperoxygenation can be useful. So it's not only about TGA, it can be useful in some other conditions as well.
So this was a mother, married for 5 years, 3rd-degree consanguinity. She was referred for a first trimester ultrasound. The history was, first pregnancy was terminated at 23 weeks because the baby was supposed to have some complex CHD. They had the complete reports, which was done in one of the smaller places, but still the interpretation was not correct, but still we could see the images and it looked like AVSD and with this probable single ventricle physiology. But at that point in time, amniocentesis was done elsewhere and karyotype was reported to be normal. And this pregnancy, these were the ultrasound images for the baby. And our diagnosis was common AV valve with pulmonary atresia and functional single ventricle. So we all know that AVSD doesn't always mean Downs because the anatomy varies. The AV canals of Downs is very different from non-Downs babies. And in such cases, in such anatomical variations, there's absolutely no role for karyotyping or microarray. So, but why does this recur? What is the chance that an AVSD can recur for a couple? So, we need to get a proper history. And because there is a recurrence, we are thinking of some genetic problem. And should we do a CVS? Solving the puzzle, we arrived at a diagnosis of right atrial isomerism. And why does the differentiation matter? What is the difference between the AVSD of Downs and isomerism? It's quite a lot.
So essentially, So essentially, in a Down syndrome, it's a balanced AVSC, and the long-term outcomes after surgery are very good. And whereas in isomerism, you have essentially usually a single ventricle, and there might be associated non-cardiac abnormalities as well, including malrotation as well as CNS abnormalities. A small but significant proportion of isomerism can be related to single gene disorders, and you might need to test them. So this, because isomerisms are generally associated with slightly poor outcomes compared to other forms of CHP, this family opted for termination. So this was our, we done an autopsy. This was a 14 weeks old fetus, if I'm right. So that's why the baby is very small. But you can make out that the heart is pointing towards the right. There is a large midline river. And if you look at the tracheal branching, there are bilateral short and vertical bronchi, suggesting that these are bilateral right bronchi. And in the abdomen, the liver, as you see, is in the midline, but there is no spleen visualized. Next. So we've done a chorionic villus sampling prior to termination of pregnancy.
And we found that the baby had a likely pathogenic variant in GDF1, and this was consistent with right atrial isomerism, which is known to have autosomal recessive inheritance. So interestingly, in our unit, like we have isolated 2 Indian families who are positive for this GDF1 gene in homozygous form, and hence isomerism can be familial, and a proper echocardiogram delineating the anatomy accurately will help us to arrive at such diagnosis, and this is going to be a useful piece of information for the parents in the next pregnancy, as we all know. This was a mother, again an interesting patient. Actually, the mother and the baby were referred to us. Primarily, the pediatrician was treating this baby, referred at 10 months, labeled as cardiomyopathy in Trichy or somewhere, and the baby was on treatment. And then when the mother had told that she was pregnant again, she had sent both the mother and baby to us for further evaluation. And we could see that in the echo image, this is the baby's echo, postnatally the 10-month-old echocardiogram, which is not normal. It is a large dilated LV.
So whenever you see dilated cardiomyopathy in a young infant, there are only very few differential diagnoses. Once we had ruled out most of them, we had a very high suspicion that this could be a genetic condition. So one of the, the importance of getting a detailed family history and a three-generation pedigree cannot be stressed enough. So in this particular case, the maternal great uncle had died of a heart condition. They did not know what exactly the condition was, but when we asked them to get some records, they had some prescriptions which had digoxin, NVAS, and lacilactone. This suggested that there was LV dysfunction. And that particular uncle also had diminished vision from adolescence, but there was no other family history which was contributory. So we ruled out most of the associated differential diagnosis, and this left us with a suspected genetic condition. So we strongly recommended genetic testing for the baby, and this baby actually had Alström syndrome. The parents were not consanguineous, so this was actually a compound heterozygous. The mother and the father had 2 completely different variants. But this also meant that there was a 25% risk in subsequent pregnancies. And as the mother was pregnant at that time, it was imperative that we test that pregnancy as well. Next.
So many a times, like when we hear that the previous child died because of heart problem, it may not be always structural. It can be conditions like these cardiomyopathies. And interestingly, in the past 3 years, we have seen 6 Alstroms, which was even like surprising for us. And amongst them, one interesting patient was referred as dilated cardiomyopathy. As Maniram told, like that the common differentials for LV dysfunction and dilated LV in pediatric age group is to rule out Al-Kappa, which is anomalous left coronary artery from the usually presence in less than 6 months of age, and other is myocarditis, like viral myocarditis in all those. And of course, if we rule out that, then we have to think of genetic abnormalities. This particular baby was 3 months, diagnosed as dilated cardiomyopathy, and the baby was referred to our OPD, and the baby collapsed and died in the OPD, literally. And then what we did was, we did was like a virtual autopsy, a postmortem echo, because we can certainly rule out Al-Kappa. The baby was 3 months old, and if we are ruling out Al-Kappa, then we can easily say that it is likely to be genetic disorder. And we tested the tissue of this died baby, and we found that that baby also had Alstrom's syndrome. So this was a mother referred for enlarged heart at 22 weeks for a detailed cardiac evaluation. She was a primary mother, and these were the pictures, and it was tricuspid valve dysplasia, non-epsteinoid form with severe tricuspid regurgitation, and we also gave it as a possibility of evolving functional pulmonary atresia and with poor RV function. So certainly there is a risk of IUF, the intrauterine demise in such anatomy, and they chose to stop the pregnancy because it was not a very good outcome problem.
And this was a cardiac autopsy. So you can see that as soon as you open the chest wall, the heart occupies the entire thoracic cavity. You can see both the lungs are completely pushed to the side. So they are very underdeveloped. The entire mid portion, which you see in the second picture, is the heart. Once we took the heart out, the right atrium is next. The right atrium is hugely enlarged, and you can see that the left atrium is smaller in size. The pulmonary veins drain normally into the left atrium. Next. The connections were otherwise normal. The tricuspid valve leaflets, we have pointed them with this yellow long arrows. They are not shifted apically. So this is non-epsteinoid. You can see that the leaflets are very thickened and dysplastic, but there is no apical displacement of the tricuspid valve leaflets. So this is a non-epsteinoid tricuspid valve dysplasia. Next. The other connections were normal.
Yeah, and I'm stopping there, and I'm just showing a similar patient because this was a 25-year-old primary mother referred for anomaly scan, and referred for a growth scan. Anomaly scan was done elsewhere in Hyderabad. They were living in Hyderabad. Anomaly scan was normal, and at 28 weeks they had reported a dilated right atrium and right ventricle. She was advised to stop the pregnancy because they felt that it's not a good disease. And then since she belonged to Delta district, she came here. And the reason for coming was to meet an obstetrician to stop the for termination of pregnancy. And she was asked to get an opinion from us. And this was the image. So like we told that there was moderate tricuspid regurgitation with mild to moderate right atrial and right ventricular dilatation. But still, this was not a bad anatomy at all. And we counseled her enough, and we asked her to come for follow-up scans. And then we gave this as a diagnosis, mild tricuspid valve dysplasia with a non-epsteinoid type. Though the tricuspid regurgitation was moderate, the RV function was good, and there was no evidence of hydrops. Hence, this is considered to be a favorable anatomy with a good long-term outcomes, because postnatal period, the PA pressure, after it drops, it's likely to improve. That's what our cardiologist said. And we followed up the baby till 38 weeks.
So this baby was electively delivered at term, and the baby did not require much of ICU care at all. Was discharged home on day 3, and subsequently the amount of tricuspid regurgitation actually came down. Still has mild tricuspid regurgitation at 6 years of age, but is completely asymptomatic. So again, just to stress, it is we had 2 patients with very similar outcomes, but it is important that we understand the disease spectrum and manage accordingly.
This was a primary mother, natural conception. The mother herself was diagnosed to have complete heart block, and she had endocardial pacemaker at 18 years of age. And then she got married, and she was absolutely fine, asymptomatic with the pacemaker. And she fell pregnant soon after she got married, no issues with fertility. And at 20, anomaly scan was normal, done elsewhere. And at 26 weeks, the baby had normal growth, but it was noted that the Leica was dropping. And again, at 27 weeks, after 1 week, she was referred for a scan in her local place itself. And she also complained of decreased fetal movements. And there they documented normal growth with oligohydramnios. And hence the referring doctor, the obstetrician, wanted to plan the delivery because 39 weeks, third scan also showed that there was some abnormality with the liquor and growth and something was not normal. And so when she came to us, she was 39 plus weeks. And the obstetrician told me that she wants to deliver the baby if we feel that the baby is not okay. And when we did the scan, the fetus was structurally normal. The fetal heart rate was normal, 140 to 158 beats per minute. But all the biometric parameters were hovering between 5 to 10th percentile. And the liquor was in the lower limits of normal. So a quick thought process for all of you. Like, so what do you think? Like, is it SGA or FGR? Should we deliver the baby or should we closely follow up the baby and give some more time because 29 weeks is not a good time to deliver? Or are we missing out something? So what are we going to do next? So when I looked at the mother and she complained of reduced fetal movements and she was having a kind of breathlessness, mild breathlessness, and the maternal heart rate was 65 beats per minute. And we asked her to bring the last pacemaker check report, which was this, Maniram.
So this mother actually had a pacemaker inserted, which was set to pace at 60 beats per minute. So now we know that the heart rate normally increases during pregnancy, but this mother did not have the capacity to increase her heart rate. Ideally, we should have something called, you can see that on the top part, it says the mode is DDD. Ideally, it should be DDDR, which allows for some degree of rate responsiveness. But because this was not correctly programmed, the lower rate was only 60. And so the mother was not able to augment her cardiac output enough to meet the demands of both the fetus as well as the mother, which was the reason why the baby was going in for a UGR. So what we did was we fixed that. We increased the rate of pacing in the mother to 80. And within a week, we were able to see a small improvement in the growth centiles.
And we took that pregnancy till 35 weeks and the baby was completely fine. I think 36 weeks and the baby was completely fine. So like these are all the small things which we can even find out even when we do a fetal scan, though it's like a hardcore cardiology part, we can suspect all these when we carefully think about all these lines. And this was a primary mother referred as bradycardia at 26 weeks. The Dopplers showed this and the M mode was as shown in the picture and it was suggesting 2:1 AV block, but the maternal antibodies were negative.
So whenever you see persistent 2:1 AV block, then this is less likely to be a antibody-mediated heart block. So what do you think are the alternative diagnoses? Anybody wants to take a guess?
I don't think there is an option to.
Next. So generally, if you have persistent 2:1 AV block, then the likely diagnosis is something called long QT syndrome. These fetuses are at a risk of tachyarrhythmias even in fetal life as well as intrauterine fetal demise. The family were counseled about this. They are closely followed up and then delivered at term. An ECG at birth confirmed our diagnosis of long QT syndrome, and we started the baby on appropriate therapy. Again, genetic testing is mandatory in this subset because your genotype is what drives the treatment. So there are a lot of treatment options. It can be just pharmacological. You might need to put in a device, especially an ICD. And again, this is dependent on the clinical response as well as the genotype. This is not the only situation where you suspect long QT syndrome. Yes, 2:1 AV block is a form of high degree AV block and very suspicious of long QT. But sometimes even if you have persistent sinus bradycardia, like you have looked at the fetus on multiple settings and the heart rate consistently remains below 120 per minute, you might think of long QT syndrome. It is important to go and ask a family history of sudden death, drowning deaths, any unexplained deaths in multiple family members. One other place where you have to think of these rare conditions is when you see premature atrial contractions starting from the second trimester itself. So PACs in the third trimester are generally very benign. All of you would have seen many of these cases in your daily practice. But when you see premature contractions in early fetal life in the second trimester, think of these conditions and get a cardiac evaluation done. So channelopathies, as we had mentioned, these are genetic disorders. Most of them are autosomal dominant in nature. So even if you have a bad outcome in this pregnancy, if you're able to do a complete evaluation, you can there is a 50% risk in subsequent pregnancies, and you can prevent that. And more importantly, in many of these cases, the parents might also actually be at risk. So we have had at least 7 or 8 instances where either the parents or other family members have had to have a device implanted after the diagnosis was made in the child or in the fetus. So the presentations can be varied. There can be history of syncope, there can be seizures with specific triggers, seizures when they listen to sudden sounds, or seizures related to diarrheal illness, or even atypical forms of febrile seizures might raise the suspicion of a channelopathy. Now remember, up to 20% of unexplained infant deaths can be related to these channelopathies. It is not just about children alone. Even sudden deaths in young adults, a majority of them are due to genetic cardiac conditions. Now we hear this all of the time. No? We hear of people dying when they are working out in the gym, dying during anesthesia, deaths during drowning, deaths while jogging. So many of these are due to genetic cardiac conditions. There are only 2 large subsets. It's either hypertrophic cardiomyopathy or it could be channelopathies. And a cardiac evaluation is mandatory for surviving family members. This should include an ECG and echocardiogram and also a genetic study if there is a very high risk based on further evaluation. So we actually had a very interesting family where the mother, a pregnant mother, was referred to us. Her brother was an IIT graduate, and he was doing a morning jog in IIT Chennai when he suddenly collapsed and died. A diagnosis was not made in him, but when this mother came to us for evaluation, she came for an anomaly scan. Looking at this history, we got an ECG and echocardiogram for her, and it turned out that she had hypertrophic cardiomyopathy. So we are able to not only help the mother during pregnancy, but we are able to also do genetic testing and ensure that her fetus was not affected.
So this was totally the antenatal evaluation for this particular baby was done in Chennai, and we collected the history retrospectively. The primary mother, fetal sinus bradycardia, with a heart rate of 110, not exceeding 120 at any point in time in all those scans. And she was labeled to have persistent sinus bradycardia in second trimester and third trimester. The baby was taken till term and delivered at 38 weeks. But what happened to this baby postnatally? So postnatally also the baby continued to have this kind of sinus bradycardia, and ECG was done which confirmed. And then?
So I was consulted remotely for this baby. So it was labeled as long QT because the ECG was abnormal and genetic testing was done. And beta blockers were started. But despite good beta blocker therapy, there were recurrent episodes of syncope, which is why the baby was referred to us at 10 months of age to consider second line management. Next. So this was the ECG which was performed at birth. So the QT interval was very prolonged. So normal QT interval is around 450 milliseconds. In this particular case, it was 720 milliseconds. And initial genetic testing had been reported as negative. When we looked at this ECG, we knew immediately that this was not the routine long QTs which we see, but an atypical form of long QT. And atypical long QTs are more difficult to manage than these typical forms. So what we did was we got the raw data from the genetic testing initially and reanalyzed this. And on reanalysis, we identified that this child actually had Timothy syndrome, which is probably one of the most severe autosomal dominant forms of long QTs, and an atypical form as well. Next. Now, it was actually referred to me for initiation of second-line medications, but unfortunately, Timothy syndrome does not respond to second-line medications as well. And the only treatment modality which could potentially be life-saving is insertion of an implanted cardioverter defibrillator or an ICD. This baby had the procedure at 14 months of age and is probably the youngest in the country to undergo this treatment. Next. So again, Shai.
Generally, we talk about genetics. It's all about phenotype, genotype matching, which we are very well aware of. And that's when we seek the help of geneticists, because we don't know a lot of things like with regards to dysmorphism or any specific structural factor which could support the particular genetic diagnosis or the particular variants. But whereas when it comes to cardiac genetics, it's always very unique, because apart from this clinical phenotype and genotype, there is something called cardiac phenotype, which only a proper genetic echocardiogram or a proper ECG can help us to arrive at the diagnosis. And that's why I feel the involvement of a pediatric cardiologist is very important when we are suspecting or handling cardiac genetics, inherited arrhythmias. And as he always says, like, one of the most gratifying things in cardiology is to treat all these babies or adults, whoever it may be, and most of them are like easily manageable with medical management. And of course, when we arrive at the genetic diagnosis, if it's the bad end of the spectrum, we can always offer termination in the subsequent pregnancy, or we put them, even the parents, the siblings, the extended family. We have done cascade screening for the entire family members, and we have started them on gene specific, the variant specific therapies, and thereby we are helping the entire family from avoiding the risk of sudden death. So it's always a teamwork, as we all know, between the pediatric cardiologists and other pediatric specialists, geneticists, and our role is, of course, very important in the antenatal scans.
Again, it's important, not especially with greater access to genetic testing. Many of us are able to do these testings even in smaller centers. But just a word of caution, the most important, looking for a causative genetic variant is like looking for a needle in a haystack. So you have millions of base pairs in your genome, and you need to identify one change, and you need to know whether that change is causative or not. For that, you need to have the entire phenotypic information available. Only then can you have a correct diagnosis. And in the absence of proper phenotyping, you might end up with completely wrong results. Next.
So we did a study in our unit with our small subset of patients for the past 4 years, and we found that about 33% of the reports provided by the genetic labs weren't actually correlating with the cardiac phenotype. Hence, we had to do a reanalysis, as we had showed some of the patients here, and then find out that we converted it from VUS to pathogenic in a totally different gene, and so on and so forth. So always it's very, very important that we need to be very careful when we interpret the lab report, and we should not just take as it is blindly, because the other person sitting in the lab is a technician and not clinicians.
I think, with some of these examples, we have sort of convinced you that many of these congenital heart diseases can have very good outcomes. But the key thing is to make the right diagnosis at the right time and guide the family appropriately. It is not the job of only the pediatric cardiologist alone or only the fetal medicine person alone. You need to have the pediatrician, the neonatologist, the obstetrician, the pediatric cardiologist, the cardiac surgeon, as well as the fetal medicine consultant, working together and speaking, in the same wavelength to the family, to help the family understand what to expect postnatally and to deliver the care for the baby as well. So even in a small center like us, we have managed to identify and treat more than 5,000 children within a 7-year period by either cardiac intervention or surgery. Again, this would not have been possible as a single person. It is a teamwork.
And we are happy that we do not deny any family who are not affordable as well. And somehow we managed to provide financial assistance to treat these children. Now we have extended our services even for non-cardiac surgeries and newborn surgeries. So learning is not a destination and it's a continuous process. And thanks to all the entire team who support us with doing such work in such a small place, that's very important. And we feel happy that we are able to do this in a small place. And thank you very much for all your patient listening.
That was amazing, and it was awestruck. Everybody was awestruck with your kind of work, what you are doing in Tanjavur. I have decided that this should be a part of our annual meeting at Society of Fetal Medicine, Tamil Nadu chapter. This was an excellent presentation by a duo doing an excellent work in a peripheral center like Tanjavur.
Thank you, sir.
Let me hand over to the moderators to give their comments and take up the questions.
I think beyond doubt, this was a wonderful presentation. And I think I won't be able to make any discrete comment right now because the number of cases were presented. So maybe in case there are questions, and that would be a good idea for me to make any suggestions or so.
I would like to ask Dr. Maniram.
I'm not too sure what was the audience group.
Audience group is fetal medicine specialists.
I think then maybe I'm not sure whether this was they were reasonable carry home messages for them.
Fetal medicine specialists, radiologists, as well as obstetrician gynecologists, sir.
I think we needed more carry home messages for them rather than case disposition.
I would like to ask Maniram how to diagnose a long QT syndrome antenatally, apart from finding out atrial premature contractions in the first trimester. If there are any other criteria in the second or third trimester where you can make a diagnosis of a long QT syndrome? Bradycardia.
Just a high index of suspicion, sir. If you have any family history of sudden unexplained deaths, and if you have persistent fetal bradycardia, so even if it is sinus bradycardia, if it is consistently below 120 per minute, then you need to think of long QT syndrome. Again, as we had shown in the case, one of the condition where you think of long QT syndrome is 2:1 AV block. So it is very rare for you to see consistent 2:1 AV block in autoimmune heart block. So in autoimmune heart block, 2:1 AV block is just a transient phase before it moves into complete heart block. So you might see it in one day, even the very next day, it will have gone into complete heart block. But if you see persistent 2:1 AV block, that is where you think of long QT syndrome. And one other place where you should think about it is unexplained IUDs in the third trimester. Sir.
I think let me take another piece of information for you. Now we have a recent data that if you do an IVRT, isovolemic relaxation time, and if it is more than 80, that actually correlates with the a prolonged QT interval. Yeah. So that is a very good marker, which we never had that in antenatal period. Now we do have that marker, which we can use in IVRT. Unexplained sinus bradycardia or a 2:1 AV block, like you showed that ECG of a prolonged QT interval, that was associated with the 2:1 AV block also on that ECG. So all those are a kind of a marker for a prolonged QT interval. and that can be assessed. And one piece of kind of a carry home message for the fetal medicine specialist, that in case you have a 2:1 AV block or a first degree AV block, this is where you can do something. You can give steroid, or you can give immunoglobulins to actually prevent a complete heart block to happen. In a 2:1 AV block, the common contender or a confusion happens in patients with an atrial ectopics coming in bigeminy. So now if you have a blocked atrial ectopics coming in bigeminy and 2:1 AV block, they look absolutely alike. There are differences, but many a times the differences are not really marked. So in this case, what I do generally, I request for an anti-RO, anti-LA antibodies and start steroids. Because if I wait for the report of these antibodies, the complete heart block might develop while I'm waiting for the report to come. So I start steroids, and then I stop steroids the moment I get the report as normal, or I continue steroids in case the anti-RO, anti-LA antibody. So this is a common tricky situation but in case you have a complete heart block, then nothing works.
It's a nice point to, that is increased IVRT of more than 80 milliseconds. Is it, sir?
Yeah, 60, less than 60 is normal. Between 60 to 80, you have a patient, and more than 80 are the very prolonged QT intervals, which, so it's a very simple graph, and it's not really very difficult to, so that's a recent paper, I think, published last year.
There are a lot of other accolades for Dr. Maniram and Usha Ramaniram's talk. Great talk, great presentation.
Can I make some observations?
Yes, sir. Yes, sir. Please.
Okay, sir. First, thanks very much for the opportunity, sir. Next, I would like to, my association with Maniram is more than 15 years, so full disclosure there. And we have been friends from our pediatric days. Most importantly, sir, as Dr. Usha and yourself, basically, both of you keep saying small place, small place. I don't believe it in anymore. Even though I am from Chennai, I always feel it's the brains that matter. I'm aware of the good work you are doing yourself, sir, first. And of course, I know Maniram and Dr. Usha doing their work from the time they've started their center. So I feel the center or the place doesn't matter. Everywhere there is accessibility today. We just have to look for it, sir. And everybody says, it's a nice adage in Hindi, when Dune se Bhagwan bhi mil jata hai. When you look, you can find God. And that's what it is, what they are showing. So it's perseverance and persistence is what it is, and high index of suspicion. Most importantly, I would like to say the history, sir. As a fetal medicine, as people who are here mostly are fetal medicine and who are interested in antenatal ultrasounds, I would succinctly say that, history is paramount, as Dr. Mani just kept insisting again and again. He might not have put so much pressure on those things, but I would like to say history is very, very important antenatally. And then we have to, genetic testing has become the norm more than the exception today. And it is available all over the country, is what I say. So you don't have to really struggle too much. And most importantly, and everything else, the argument that patients might go away, patients might not work towards it, or patient might not accept. We have to offer the patient what we have on table, saying them and convincing them to go in for genetic testing, so that we can pick up more. The amount of population we have and the amount of genetic materials we have is vast. And I can not emphasize the importance of genetic testing for a suspected fetus, so that we can, have our data, so much so data that we can actually have a huge volume of data from what we, as one center with Dr. Usha and Mani can do so much. As a collective group, we can do much, much more. And secondly, since we are concentrating on pediatric cardiology here, cardiology and pediatric cardiology, there are pediatric cardiologists throughout the country. Whenever we are in doubt or anything else, they are only a video call away today. So I think we just need to, where they need expertise or need for counseling, we can always just hook on to the patient to a video counseling with the closest pediatric cardiologist. So they can give their insight. I'm not a practicing fetal cardiologist. I sit with a fetal medicine person and then look at the images and then give my opinion on the patients. I do a lot of antenatal counselings, and this is what I tell them. I'm fortunate to be working in Chennai and having like that. But since there are multiple centers across the country, and today I understand that there are a lot of remote centers as well, but we are having high-speed internet. I think 5G is available throughout the country, and we can establish a small video calling center where the patient can connect with the pediatric cardiologist where the pediatric cardiologist is not available, so as to plan the delivery is what I would say. I take a lot of inspiration from these two for encouraging in genetic testing. I request the audience as well to have, encourage their patients to go in for genetic testing so that we can move ahead as an entire group and society who care for fetuses and children. That's about it. Thank you, sir.
Thank you. Thank you, Karthik. There is one more question. Sir, any gender preponderance in long QT syndrome?
Actually, it's an autosomal, most of them are autosomal dominant. So there's no general preponderance aspect. But clinical effects, sometimes, females might have worse disease in long QT1 compared to males. But as far as diagnosis is concerned, there's no gender preponderance. And in long QT2, sir, postpartum mothers are at a very high risk of arrhythmia storms. So many of them might need an emergency ICD in the immediate postpartum period. So such clinical gender differences might be there, but as such for diagnosis, there's no gender difference.
One of your cases, you showed that Noonan syndrome with bilateral pleural effusion, which you drained postnatally, did very well immediately after drainage. There was no recollection, you said. And why was it not attempted antenatally?
Actually, we plan to, generally we always tap the fluid and only deliver, but she ruptured her membranes. So we had to deliver her emergency.
Even if that had been done antenatally also, the same result would have happened, isn't it?
Yes, sir, but yeah.
That particular patient we had planned for, pre-delivery tapping, sir. But she came at 36 weeks with the PPR.
Karthik wanted to say something.
No, sir, nothing. Just.
And there is another question from Nikhila. She wants to know what is the dose of steroids which are recommended. And Dr. U.P. Singh only commented about steroids to be started immediately. Dr. U.P. Singh, sir, can you unmute yourself? One of your cases, you said the steroids made her the prognosis very worse, and it developed IUGR and it died in utero. One of your cases, you said.
Yes, sir. Yes, sir. Yeah, actually, I think that was not managed here. That was from the history. So the baby had complete heart block at 24 weeks, I think, and then she was started on steroid. That was the second pregnancy. She came to us for the next pregnancy. So supposedly, it must have been steroid induced like IUGR, and it's known to cause oligohydramnios and all those. So we assume that it should have been because of that, because per se there was no hydrops documented. So the report said that it was growth restriction, oligohydramnios, and IUD. That was the sequence documented in the previous pregnancy somewhere else.
So what's the recommended dose?
So you have to use fluorinated steroids. So you have to use either betamethasone or dexamethasone. So generally what we use is dexamethasone at a dose of 4 milligram per day. Sir.
Okay. Okay, that's all the questions. And your demonstration of that Raskin's balloon septostomy through umbilical vein catheterization was excellent. We were amazed by that video, and it was really good. And our professor, Dr. PCR, used to say, though it's called as a Raskin's procedure, though it's a rash procedure, it is a very kind procedure for the fetus, for the baby. It is a way to remember what is balloon sepsis. There's a mnemonic. Rash
Yeah.
it's a rash procedure, but it's a very kind procedure.
Okay.
It was also amazing. So
Conventionally,
excellent
like,
presentation. I have decided that this should be our your lecture should have a place in our annual meeting.
Thanks, sir.
Nice.
Thanks a lot for your kind, generous
Thank you very
words,
much.
sir.
Thank you very much for our invitation and your acceptance of our invitation and presenting such a wonderful lecture. And the audience were jam-packed. It was always 100, always, and nobody left the hall during the meeting. Thank you very much for absorbing presentation. Thank you, sir. Dr. U.P. Singh, sir. Thank you very much, sir. And
Yeah,
Dr.
thank you.
Karthik
Thank you
Surya
very much
also.
for having me. Thank you
Thank
very
you,
much.
sir. Thank you,
Thank you,
sir.
sir.
It's
My
an
pleasure, sir.
extreme
Thank you.
pleasure to have you with us today. And Dr. Karthik Surya also, extremely thankful to you for your valuable inputs. Thank you.
Thank you, sir. Thank you.
Thank you.
My pleasure.
We'll organize similar meetings in the future also. Thank you.
Yeah. Thank you, sir. Thank you. Yeah. Bye,
Thank
sir.
Many appreciations and accolades for you.
Thanks,
Thank
sir.
you so much, sir.
Means a
Thank you.
lot. Yeah. Thank you.
The meeting is recorded, and I think we'll make it available in the social media, either in the YouTube or some other place. Thank you. Thank you all.
you.
Those who have not had an opportunity to attend the meeting will definitely have an opportunity to hear it online.
Thanks, sir. Thanks.
Thank you, Dr. Usha Nandini. Thank you, Dr. Maniram. Danyashri also was excellent in her presentation.
Thank you,
Thank
sir.
you, Dr. Danyashri.
Thank you, sir.
Thank you. So many are still appreciating. It was an excellent presentation. Thank you.